Is that popping up now? Yeah, great. So hi everyone, probably had a huge day so far, so I'll try and get to the point with this. So I do an endocrinology and MSK. It gets a bit buzzwordy by the end, so Liv, if I'm going over time, just stop me and then they can go in the post slides about that. So these are the conditions I'm going through. I've mainly focused on green conditions and sort of approaches for OSCEs and stuff. And some things I haven't covered, which is sort of like in adult medicine and things like, or in other presentations. So endocrinology. So a big one is type 1 diabetes. So type 1 diabetes is a common pediatric autoimmune condition that's characterized by chronically high blood glucose levels. And this occurs when the body creates antibodies that attack the beta cells in the pancreas, which secrete insulin. So as you can see here, as antibodies increase, your beta cells mass decreases, and this leads to your overt diabetes. So it leads to a point where the children can't produce any insulin at all, and they can't utilize the glucose in their blood. This occurs usually from genetic factors, but there's a lot of research to show environmental factors also cause this. And the clinical presentation is often, if they haven't been diagnosed before, in an emergency in DKA, which I'll talk about in the future slides, but also those osmotic symptoms of polydipsia, polyuria, nutritional symptoms of polyphagia, weight loss, stunted growth, and then having a family history of autoimmune conditions such as thyroid and celiac disease. So there's all these tests that you would be aware of how to diagnose diabetes. And so for diabetes, you need to have 2 of the above tests or 1 of the above tests plus symptoms. And this is just to determine diabetes. So the type 2 diabetes can occur in Paeds kids, but is not very common. So to confirm type 1 diabetes, they test the antibodies. So these are some buzzwords to keep in mind for the exam. So anti-GAD, anti-IA2, which is islet cell antibodies, anti-insulin, and anti-zinc transporter 8 antibodies. These take a while to process. So if it's an emergency situation, they're going to treat like type 1 diabetes with insulin anyway, but this is usually to confirm in the clinic a couple of weeks later. And then testing for autoimmune conditions. So thyroid is very common with type 1 diabetes and celiac disease. So with type 1 diabetes management, the aim is education, education, education. So usually kids are discharged from the hospital once the diabetes nurse educators and everyone determine that they're at enough of a level of education that they can look after diabetes by themselves. So the reason being that it's a very treatable condition. You just give them insulin and they don't go into, that manages their glucose levels. The issue following that is if they're not compliant to insulin. And it's quite hard to be compliant to insulin because there's a lot involved in it. The other things for families to be aware of is when it's too low, too high, or the kid's too sick. So if they're too low, that's a hypoglycemic plan. So they need to be aware of the symptoms, give short-acting carbohydrates like with jelly beans, or if they're altered conscious state or fitting, then you give them glucagon, which does the opposite of insulin. If it's too high, then they go into DKA, so they've got to check the ketones and present to the ED. And if it's too sick, so if they're not eating when they're sick, then you wouldn't give short-acting insulin for that meal. And if they're got an illness like a respiratory tract infection, they might develop insulin resistance. When they're sick, they tend to get resistant to insulin, so therefore they go hyper. So you might increase their long-acting by 10%. But if they got gastro, then they tend to go hypo because they're not absorbing carbohydrates and stuff, so you wouldn't increase insulin. So a lot of talk about insulin, so I'll talk about that. So insulin, they aim to give kids 1 unit per gram per day, and they have a few different regimes for this. The main one is the basal bolus regime. So what they do is they give short-acting insulin for every meal, which is usually Novorapid, and then a long-acting just before they go to bed. So the Novorapid usually acts about 15 to 30 minutes. So they give it about 10 to 15 minutes before a meal. And then the long-acting, they give at night, and that usually lasts for about 24 hours. The pros for this is it really mimics the pancreas really well. So the pancreas usually has a low level of insulin in the body at all times. And then they have surges of insulin when you start eating with meals. So it mimics it a lot, and you get tighter control of glucose levels. However, the problem is you get 4 injections a day, 1 for every meal and 1 before bed, plus the 4 pricks of your finger that you're checking BGLs throughout the day. So there's a lot of pricking a kid. So they sometimes switch to the mixed BD regime, which is 2 injections of what they call Novamix, which is 2/3 of short acting and 1/3 of intermediate acting insulin. So they give this once every 12 hours, so like 7 a.m. and 7 p.m., for instance. And the idea of it is that you get these 2 peaks. So you get the short acting peak here, and then the intermediate acting kicks in, and you get another sort of peak like that. And that covers you for about 12 hours, a bit over 12 hours, maybe 15 hours. And that overlaps with your second injection. So this is good for instance, kids that can't give the insulin themselves. So if they're less than 10 years old, for instance, and then the parents have to do it, so they can do it before work and after work. Or if they really don't want to have the 4 injections a day, then they can just do the 2 injections. But the problem with this is it poorly mimics the pancreas because you don't get that surge of insulin for lunch. And if you miss an injection, so as you can see here, the first injection will cover you to like 3 a.m. and then between 3 a.m. and 7 a.m. Will have no insulin on board. So therefore you can lead into DKA very quickly. So then there's also an insulin pump. So that's the one shown here on the right. Over this side is a continuous glucose monitor. And an insulin pump delivers a constant amount of short acting insulin in the body, and that acts as your basal insulin. And then into the device, you key in how many carbs that you've eaten, and that will give you a surge of a bolus of insulin for when you're eating that food. So really good because it adjusts basal insulin according to your body a lot more accurately. However, you have to count your carbs very closely. And if you get a blockage in the line of the insulin pump, that means you have like no insulin on board straight away because there's only short acting being delivered. So you can lead into DKA really quick. So they tend not to give insulin pumps to families that aren't very good at basal bolus regime. So it's actually quite hard to manage an insulin pump. So you wouldn't give it regularly. And then there's a new regime of Ryzodeg. So what Ryzodeg is a combination of this, as you can look here in the basal bolus regime, combination of a short acting insulin and a very long acting insulin, which lasts for about 72 hours. And that's if people aren't taking their bedtime insulin. And then doctors would stress, be like, make sure if you're going to take any insulin, take your Ryzodeg because they'll cover you and stop you from going into DKA, even if you have poor control. But the problem with that is because it's a combination of the two, if you want to increase your long acting, you will also increase your short acting. So then it's very difficult to titrate according to your meals. So with type 1 diabetes, you've got to monitor. So usually for type 1 diabetics, you monitor 5 years after diagnosis at a minimum of 10 years. So if you're diagnosed at 2 years, you wouldn't start monitoring at 7 years, you would start monitoring at 10 years. And then type 2 diabetics are usually at the time of diagnosis, but usually you don't see them pre-pubertal anyway. And you're monitoring for microvascular or macrovascular complications and your autoimmune screening. So that will be done 1 to 2 yearly for thyroid and celiac. So I've got a few questions throughout the PowerPoint. You can just think of the answers, or if you've got someone with you, you can talk through the answer with them. But I'll just leave about 10 seconds per question for people to answer and I'll move on. So just to keep with time. So about 5 more seconds. Great, so this is a presentation of DKA. So it would be a metabolic acidosis for this. So DKA is an emergency situation from usually in type 1 diabetics, which is when the child doesn't have any insulin on board and they're either endogenous or exogenous, and the child can't use the glucose in the blood. So just a little diagram to show you here. So you've got glucose in the blood, usually insulin is used to use it in the cells, but you don't have insulin. So therefore you've got high glucose levels. And then your body needs to use another alternative energy source. So it breaks down fat and muscle, and you get fatty acids, and that undergoes ketogenesis in the liver, and therefore you get ketone bodies. And that's good for your brain because your brain can only use glucose and ketones. However, ketone bodies are acidotic, and very high levels of ketones can lead to acidosis and lead to death. So it's very dangerous. So this is very uncommon in type 2 diabetics to get this, but not impossible. The reason being that in type 2 diabetes, the issue is insulin resistance rather than not having insulin on board. So they still have insulin, so it's unlikely for them to go into DKA. And diabetic ketoacidosis in the name tells you what you need to investigate for. So diabetic, got high blood glucose levels, presence of ketones, and acidosis, so low pH and low bicarb. So signs and symptoms, you get this Kussmaul's breathing, which is this really deep breaths, and that's them offloading CO2. So you could probably remember this formula from pre-clin years where you're constantly in balance of this. And so when you have an increase of hydrogen ions, that combines with your bicarb and pushes the equation to the left. And then you've got high CO2, so you're breathing that off in your lungs. So you're compensating for your metabolic acidosis by breathing off the CO2. And then you can get altered mental state from that acidosis and nausea, vomiting, and abdo pain. There's a lot of information on this slide. It's just extra information to help you understand why we do this. But the things to remember is it's an emergency situation. So remember your doctor's ABCD. And then you manage with the acronym SPIDER. So S is saline because they're dehydrated, because they're vomiting a lot and peeing off a lot because they're diabetic. So you need to rehydrate them. Don't rehydrate too quickly because a complication of quick hydration is cerebral edema. When you start giving insulin, you will also start utilizing your potassium. So you'll lead to hypokalemia. So you've got to give them potassium supplementation. Once you start giving insulin, this will stop the ketogenesis, and they will stop developing ketone bodies, and will stop and you'll eventually clear that out. If they start looking like they're going hypoglycemic, so under 15 is when they start worrying about it, you give them dextrose. So the reason being, the issue with DKA isn't the high levels of glucose, it's the ketones. So you don't want to stop the insulin if they're going hypo, because as soon as you stop the insulin, they'll start doing ketogenesis again and go into DKA again. So don't stop the insulin, keep that going and supplement them with dextrose instead to get their glucose levels higher. Then E is electrolytes and edema. So your electrolytes will usually be corrected by this treatment anyway. And then edema, you'll monitor for cerebral edema, which usually occurs in the first 24 hours of treatment. And then R is reevaluate and revisit. So regularly recheck their vitals, GCS, BGLs, and VBG, and involve the endocrinology team and get education on board as soon as possible. There's another question, so give you 10 seconds. Great, so this is acquired hypothyroidism because it's a quite acute change over 2 years rather than from birth and getting this constipated picture. I'll focus more on congenital hypothyroidism because acquired is usually like the adult hypothyroidism anyway. But congenital hypothyroidism, so as you're aware, thyroid hormone regulates the rate at which you metabolize and use calories. So low thyroid hormone means less calories it burns, and meaning that you're not, everything's lower is usually what they say. And the causes for this is usually primary. So thyroid dysgenesis is the most common cause, which is the thyroid hasn't developed properly, or you get ectopic thyroids growing somewhere else in the body. And this is usually confirmed by ultrasound. And then the other cause is thyroid dyshormonogenesis, which is you have lacking enzymes to help create T4 and T3. and therefore you get a normal looking thyroid, but you don't have much T3 and T4. Other causes could be central, so from your pituitary gland, but you would also be affecting your other hormones usually. So your sort of GP flats hormones, so growth hormone, prolactin, FSH, LH, ACTH. And you've got your other causes, which usually don't occur in Australia and quite monitored closely in obstetrics as well. So you're unlikely to get those causing congenital hypothyroidism. So signs and symptoms of congenital hypothyroidism. So I made an acronym. It's not great, but it gets the job done, I guess, for some people. Or you can do a top to toe look as well. But essentially you get coarse facial features, hypothermia, your tongue is very big, you get this little umbilical hernia, bit of a hoarse cry, and you can get prolonged unconjugated jaundice. So if you rule out the anatomical causes of prolonged jaundice, then you've got to think about hypothyroidism. They're open posterior fontanelle, inactive and sleepy, constipation, and they're usually poor feeding, but pretty fat as well. But usually they're asymptomatic and it's found on the heel prick test, and they test for TSH. So if TSH is really high, that would indicate that there's a primary thyroid issue because your brain is trying to stimulate the thyroid to make more thyroid hormone, but it's not. So investigations for congenital hypothyroidism, so you got your heel prick, TSH, like I said, and then you would follow up by measuring the T4 as well. An ultrasound determines if there's thyroid dysgenesis or the ectopic thyroid somewhere. But if you can't find the thyroid or an ectopic thyroid somewhere, then you might do a nuclear technetium scan to see if there's uptake somewhere else. There's a syndrome called Pendred syndrome, which is linked with dysharmoniogenesis and loss of hearing. So you might do a hearing test. That's just a buzzword to remember. But if you get hypothyroidism around 6 to 12 months and you're thinking more an antibody picture, so you test these antibodies for Hashimoto's and Graves. For management, if it's dysgenesis, they're usually on lifelong thyroxine, but you got to start them as early as possible to stop developmental delay. And dysharmoniogenesis, they may be able to be weaned off over time because they'll be able to develop the enzymes to develop thyroid hormone. And then regular monitoring. So when you give them thyroxine, your T4 will respond in around 2 weeks' time and your TSH will respond around 6 weeks' time. So they usually monitor at 3 to 4 months. Great. So obesity is another green condition, but it's quite simple to manage in the sense that it's just a multidisciplinary approach, mainly involving a dietitian and motivational interviewing. So you got to look for their risk factors and then do initial screening for organic causes. So your hypothyroidism, Cushing's syndrome, growth hormone deficiency, Turner's Prader-Willi syndrome, and drugs. And then an annual complication screen. So your high cholesterol, diabetes, and fatty liver. And then, so you're trying to aim for them to get more active, try and do 1 hour of activity a day at least. Reduce their screen time, especially in lockdown. Reduce their snacking, sugary drinks, portion size, and get them a lot more vegetables and fruit on board. And if it's really drastic and really serious, then you might consider orlistat as a medication or bariatric surgery, but it's very uncommon to do that. So short stature and growth hormone deficiency are quite linked. So the causes could be constitutional delay. So that's just, they're going to grow normally, but they're just delayed in their growth. And that's usually predicted by the parent's height at the parent's age of puberty, which you would assess in the assessment. And non-endocrine causes are usually malnutrition, familial short stature, and congenital syndromes. And then endocrine, you've got your growth hormone deficiency, hypothyroidism, hypogonadism, and Cushing's disease. What's important to remember is in growth hormone deficiency, this usually occurs at 6 months of age. So if you've got short stature before that, then you're thinking more hypothyroidism or hypogonadism type pictures. And also growth hormone is pulsatile. So doing a random growth hormone test throughout the day isn't a very good indication of if they got high or low growth hormone. So you got to do a stimulation test, like get them to exercise and then measure if their growth hormone increases or decreases over that. And you also do a bone age scan. So if they've gone through puberty, their growth plates fuse and therefore they don't have any growth potential left. But if you do a bone age scan and their bones haven't fused and have lower bone age, then they could be eligible for growth hormone before they undergo puberty. Great. Protein energy malnutrition, it's not really a big thing. I'm just going to skip over it pretty quick, but just the main things is marasmus is chronic malnutrition. So they present like this with severely underweight and muscle wasting, whereas kwashiorkor is more acute, and therefore you get a protein imbalance and you get edema. So you get distension of the abdomen and swollen ankles. The other thing to keep in mind is refeeding syndrome. So in adolescent cycle with anorexia nervosa, if they get prolonged malnutrition, they break down fat and muscle to maintain phosphate, potassium, and glucose levels in the blood. As soon as you feed them, they get a huge surge of insulin and they use up that glucose, phosphate, and potassium. And so they get sudden drops in phosphate and potassium in the blood, and that can lead to cardiac arrhythmias and delirium and death. So you've got to make sure to just refeed them slowly and monitor an involved clinical nutrition. Vitamin D deficiency, which leads to rickets, is an important one to know. So vitamin D is necessary for calcium metabolism, and then without vitamin T, you get failure to from bone mineralization and leads to rickets. So there's a acronym for rickets presentation, but the main things are the bone of the legs and the knock knees, and the skull frontal bossing and delayed closure of the fontanelles. So the investigations are your bone bloods. These are the ones to remember. So calcium and phosphate are quite linked. So you've got to measure both of those. And those will be low in rickets. You get an elevated ALP from high bone turnover, high PTH as well. And you can do a hip x-ray as well to see the bone of the legs. Treated with vitamin D supplementation, but if they're very severely low calcium, then you want to admit them and monitor for arrhythmias and seizures. These are other vitamin D deficiencies. You can look at them in the post slides. Just to remember that your fat soluble ones, A, D, E, K, can be associated with cystic fibrosis and celiac disease from malnutrition, malabsorption of those vitamin D, that are fat soluble. All right, another question, give you 10 seconds. Great, so this is CAH. So CAH, the buzzwords are ambiguous genitalia, and that's sort of nausea and vomiting, shocked appearance the first month of life. So CAH is an autosomal recessive disorder that causes deficiencies in enzymes that are involved in creating aldosterone and cortisol. So if you look at this image, you probably have seen this a few times before, but essentially if you have deficiency in 21 hydroxylase or 11 beta hydroxylase, you can't create aldosterone or cortisol. And this is just pushes everything to the side and you go create more androgens instead. So with this, that's why you get the ambiguous genitalia from the high testosterone. And then you get a feedback loop because your body's like, okay, you need more aldosterone, you need more cortisol, so we're going to secrete ACTH to trigger more. But then the same process happens again where your adrenals can't create aldosterone or cortisol, sends it to testosterone, and then it's just the feedback just keeps going and going until the baby's at a certain crisis. So the way to manage it is to give them a glucocorticoid and a mineralocorticoid to stop this feedback loop, and then they'll start managing. And then maybe surgical correction of the ambiguous genitalia. And you can get the picture of classical salt wasting or non-classical salt wasting. So with the classical salt wasting, the way I remember it is like, because you're not getting aldosterone, it's like you're giving them so much spironolactone. It's like the opposite. So you get that potassium sparing diuretic effect where you're getting hyperkalemia and hyponatremia, and they're shocked. And then you get the clitoral hypertrophy, ambiguous genitalia. But the non-classical means you get some mineralocorticoid effect. So if you got, for instance, a lever-beta hydroxylase, you might be able to still develop deoxycorticosterone, which has mineralocorticoid effect. And therefore you can maintain some of that aldosterone effect. So you're not going into that severe shock, but it's still similar symptoms. Great, so that's endocrinology. So let's go into MSK now. So I think the big thing is to try and have a good approach to a limping child and an OSCE. So the way to remember it is to split it into age groups, but there's always 3 that you need to remember for all age groups, and that is infection, trauma, and malignancy. So infection, you've got your septic arthritis, osteomyelitis, and then post-infectious reactive arthritis. Then you've got trauma. So that trauma can be simply from them be like falling over, trauma from running around, things like that. Could be hemophilia, getting bleeding to joints and things, or non-accidental injury. You always got to assess for that. And malignancy, so usually in kids, leukemia and osteosarcoma. So for kids that are less than 3 years, usually it's just those 3 that would be presenting. You don't really get any other sort of inflammatory or mechanical causes. When you get to 3 to 10 years old, then you're starting to think of transient synovitis, Kawasaki disease, HSP, GIA, and then mechanical Perthes and growing pains. And then when you're greater than 10 years, you still can get GIA and HSP, but the more mechanical causes are sort of SUFI and Osgood Schlatter. So when you're doing a history of those that are less than 3 years old and just all histories in general, you just got to do your classic approach. So you do your history of presenting complaints. So time frame, is it one leg or the other or both? Is it painful, painless? Can they wait there? Then you do your classical Paeds history. So appearance, growth, developmental milestones, input, output. And then you go cover your infectious symptoms, fever, sweats, chills, shakes, red hot joint. And reactive arthritis, you can think of can't see, can't pee, can't climb a tree type of questions. Trauma, if they've got bleeding disorder, family history of bleeding disorders, blood thinning medication. Malignancy, you think of your B symptoms, and if it's leukemia, affecting other blood lines, so bruising, predisposition to infections, organomegaly. And then you got to think of other red flags. So I've marked a few red flags here, but other red flags are night pain. So if they're getting pain at night and not from weight bearing, that would be more linking to like a malignancy or infective type picture rather than caused by some sort of mechanical or inflammatory issue. And in bowel habits, changes in bowel habits or urinary symptoms and NII, and family history, drugs, and social history. So I won't go through, these are just questions to remember for specifically like sort of cluster questions for them, but I'll go through each condition to cover these anyway. So this is just for the post slides. So managing a child, if it's benign, so they've got no red flags, they're ambulating well with simple analgesia, you've got a working diagnosis or you're going to review them in 7 days, you don't really need to follow up with investigations. That's fine, you can send them home. So the big ones to worry about is septic arthritis and osteomyelitis. So the common causes of these are Staphylococcus aureus, most common, and then other streptococcal species, so group A, group B, pneumococcal. And so all these are usually covered by Flucox. So if it's uncomplicated septic arthritis, osteomyelitis, you give them Fluclox. If it's complicated by other things that are shown here, there could be a gram-negative picture, so then you have to add more antibiotics on top. So you think of third-generation cephalosporins like ceftriaxone. So there's this flow chart, which you probably are aware of maybe. If you look up on Google antibiotic coverage, this pops up. It's a great one. So as you can see here, flu clocks covers Staph aureus and Streptococcus, and that's about it. But if you want that gram-negative coverage, then you're looking at that ceftriaxone here to cover those species. For investigations, you do infection bloods and then imaging, an X-ray for septic arthritis for narrowing of the joints and early effusion. And then osteomyelitis, you think of an MRI first. If you can't do an MRI, do a bone scan. So a bone scan is like a technetium scan, so it's uptake. So if you've got osteomyelitis that's got blood flow to the osteomyelitis and inflammation in the area and breakdown of the bone, you'll get more uptake of the scan because there's of that breakdown, because bone normally wouldn't uptake that. And then so once you've done your IV antibiotics, you give discharge on oral antibiotics, and then you can think of surgical correction, so a washout for septic arthritis or surgical correction for osteomyelitis. So osteomyelitis and septic arthritis present quite similarly. So septic arthritis is, however, septic arthritis is more acute, whereas osteomyelitis is more subacute. And septic arthritis, you usually get that fever straight away, very high fever, whereas osteomyelitis may not have it initially and present a bit later with the fever. And septic arthritis gets that erythema and swelling of the joint straight away, like you can see in this picture, but osteomyelitis is quite a late sign because it's right in the bone. Otherwise, it's quite similar. And this is the picture of the bone scan, so you can see there's more uptake in when there's a site of osteomyelitis. Great. So JIA, it's characterized as a chronic autoimmune condition that attacks the joints of kids that are less than 16 years old. And chronic is if it's greater than 6 weeks. So imaging is usually not helpful for this. It's only to rule out causes. You can do an ultrasound, which will just show an effusion anyway. You'll get an elevated ESR because it's a chronic inflammation, and you can test for rheumatoid factor as a prognostic factor for polyarthritis, which I'll talk about in the next slide. But management is just mainly non-pharmacological, so exercise, getting splints, and physiotherapy. And then pharmacologically, in the short term, you give anti-inflammatories, so NSAIDs, maybe glucocorticoid injections in the joints. And long term, you can think about methotrexate and sulfasalazine. And these are the different types of JIA. So you've got your oligoarticular, so only a few, or is polyarticular, which is a lot of a joint involvement. So oligoarticular is 1 to 4 joints and can be split into persistent or extended. So persistent being it persistently stays at 1 to 4 joints, or extended meaning that it goes beyond 1 to 4 joints after 6 months, which obviously for extended will be a poorer prognosis. Polyarticular is 5 or more joints. If it's rheumatoid factor positive, like I was talking about before, it's usually a poorer prognosis and presents more like a rheumatoid picture, but it's more commonly, 95% cases, rheumatoid negative. Psoriatic JIA comes to a diagnosis if there's a family history of psoriasis or they are diagnosed with psoriasis as well, and it can have an oligo or polyarticular picture. Enthesitis associated. So enthesitis is when there's inflammation of the tendon or ligament insertion. So the most commonly is like the Achilles tendon, where it inserts there, you can get inflammation there, so heel involvement. And that's linked with HLA-B27 conditions. So your seronegative psoriasis, ankylosing spondylitis, IBD, and reactive. And you can get anterior uveitis. So those are sort of your buzzwords for that. And then systemic JIA or Still's disease involves fever and erythematous rash, so it's quite more serious. So here's another question. I'll give you another 10 seconds to answer. Great. So the buzzword's flattened femoral head there. So it's Perthes disease. So Perthes disease is characterized as a vascular necrosis of the proximal femur head. So this can be idiopathic, interruption of the vasculature to the femoral head, or secondary to some trauma or growth. But essentially, as you can see in this X-ray, you get that bone demineralization of the femoral head. And so it looks very flat, and you get this increased joint space. And it's usually worse after exercise, and you can get referred pain to other joints, so down to your knee, for instance, which was shown in that question. And there's actually good prognosis with Perthes disease. They usually get splints and casts to try and form the femoral head against the acetabulum for it as well, but might need an osteotomy to reform the hip. It's another question. I'll give you 10 seconds. Great, so the buzzword here is overweight, so it'll be SUFI. So SUFI is where when you're like over 10 years or so, you still have that growth plate yet to fuse after puberty. And that's can be quite weak, and under a lot of weight for a kid, the head of the femur can break off and slip back and down. And so that's why the buzzword is obese males, because it's usually the weak growth plate against the weight. And it presents like you would with an adult that has like a hip fracture or a dislocated hip, which is they get externally rotated hip and it's a shortened leg. So on X-ray, you can examine, they use the Klein line for this. So they make a line across the femur neck, and it should cross the femoral head, as you can see here. So that's normal. But if it doesn't cross it, then that means that the femoral head slipped off, and that's SUFI. And this usually needs orthopedic involvement and open reduction internal fixation for that. Okay, another question. Give me 10 seconds for this. Great, so the buzzword's viral upper respiratory tract infection, so transient synovitis. So transient synovitis is inflammation of the synovium, secondary usually to an ERTI. And usually you wouldn't get very raised inflammatory markers, and not like septic arthritis or osteomyelitis. And you wouldn't really do an X-ray. It's just to rule out other causes if you're thinking, but an X-ray will be normal. And ultrasound of the hip will show an effusion like this one here. It's very self-limiting, and you can give NSAIDs and lifestyle modification to manage. Well, I think I might have given the answer there. So give you 10 seconds for this one. Great. So the answer for this is Osgood Schlatter disease. So I actually had this one. So this was fun to learn about when I went through Paeds. But essentially what happens is your patellar tendon, which inserts to your tubular tuberosity, is where the growth plate is. So when you get a lot of tension on that, it can pull on the growth plate and cause inflammation and swelling of the growth plate. So if you're a very active kid that has gone through a growth spurt, a lot of contraction of the quads can pull up on the patella, and then the patella pulls up on the tibial tuberosity, and therefore you get that pulling on the growth plate and inflammation and swelling of the growth plate. So the pain is usually this very specific anterior localized pain on the tibial tuberosity, and you can feel a firm mass on there. And it's worse on exercise. So especially like the squatting or running that involves contraction of your quads. So it's usually a clinical diagnosis and doesn't really need an X-ray, but you can do X-rays to rule out other causes as well. And also once they've grown, their growth plates have fused, then it usually is managed okay and the pain goes away. but you would try to reduce their sports at the time and do a lot of rice and physiotherapy. Great, another 10 seconds for this one. Great, so this is DDH. So DDH is when there's inappropriate development between the head of the femur and the acetabulum. And so there's very unstable hips. And this usually occurs during delivery. So if they're a traumatic delivery from breech, or they can't move too much during the delivery. So if they're the firstborn or severe oligohydramnios, they can develop DDH. And it's usually this like shortened legged at the side of DDH and a stiff hip. And then you test for it on a newborn exam. So you got the Barlow and Ortolani tests. So the way I remember it is for Barlow, you're going out to the bar. So you want to take the hip out to a bar. So you're dislocating the hip. So you got your hands like a gun, you put them over the knees and you're pushing down to dislocate the hip posteriorly. And then Ortolani is it's too late to go out, so you're coming back home. So you're going this external force and you're trying to push the hips back into the socket. So when you're doing these tests, if you're getting this sort of, if you're dislocating the hip, then that would be positive for DDH. And you usually investigate with an ultrasound, and pediatricians have a very low threshold to do this because of the risk of DDH. So usually in breech, they'll definitely do an ultrasound anyway. And it's managed usually with these very cool looking harnesses, like the Pavlik and the Dennis Brown bar harnesses if they're less than 6, and a spiker cast if they're greater than 6 months. Right, so I'll go through a couple of buzzwords after this for pediatric fractures, but I think it's good to have a good framework for if there's an OSCE. I know you wouldn't really be doing an examination now in COVID, but they might ask you what you would examine for pediatric fracture. So you got to check for neurovascular, neurovascular intact. So vascular, you got your 5 Ps. So pain, pallor, pulses, paresthesia, and peritoneally cold. And then neurological, you want to test for your upper limb nerves, so median, ulnar, radial, and lower limb, so your tibial, common perineal. And then your management. So you would want to get an X-ray to confirm the diagnosis and whether it's displaced and to do reduction or not. You can do escalation of your analgesia. Intranasal fentanyl is really good if you're doing like a closed reduction and you need that fast acting, heavy analgesic effect. And then you can immobilize them. Then you would immobilize them as well with a cast or a back slab, and consider closed reduction after consultation with ortho. And then you have to immobilize below and above the site. So if you've fractured your radius, for instance, you would immobilize from your wrist to your elbow. So the joint above and below. And then always in the OSCE, just say, I'll print out information from the RCH website about cast care and about managing this, because that would be like good tick, tick, tick for the OSCE. And good thing, kids heal better than adults, so they less likely need rehab. So just some buzzwordy things to remember for the exam. So buccal fracture. So the way I remember it is buccal equals bulge. So you get this bulging of the cortex. You can sort of slightly see here. That's fine. Usually no ortho referral needed. Just immobilize them and get them to follow up with a GP. Greenstick fracture. So greenstick, think of like the way I remember it is a branch on a tree that's been sort of snapped in half a bit and sort of dangling there. So it's not completely snapped off, but it's just still hanging on by a thread. So greenstick fracture is incomplete fracture of the long bones. And usually this needs an ortho follow-up in 7 to 10 days. And you might consider at the time, if it's really displaced, doing a closed reduction of it after consultation with ortho. Then you got your Montesia and Mellitus fractures. So a kid's been attacked by a mugger. So MU is Montesia and ulna. So you get fracture of the ulnar shaft from Montesia. And then Mellitus and radius. So GR, you get fracture of the radial shaft. This is usually from outstretched hand and will need orthoreferral and open reduction internal fixation. And then finally, you got your supracondylar fracture. So your condyles are like the prominences on your elbow. So it's just above that. And there's serious complications with this because it can interfere with your brachial artery. So you can get compartment syndrome there and ischemia of your extensors and flexors. So your extensors and flexors can contract and you can get that Volkmann's contracture that is shown here. And you get absent pulses and sensation. If it's a type 1 like this, hasn't been displaced, usually it can be follow-up later, no correction needed. But if it's type 2 or type 3, then you'll probably need open or closed reduction internal fixation. Great, so that's all my slides. Thanks for putting up with me for this. I know the exams are stressful, but please look after yourself, look after your friends, check in with them, and thank you so much for your time.